Now, when we have a patient of a red eye, or he is presented to you with a red eye in the outpatient department, one should know how to go about and take the complete detailed history in this particular patient. Has he undergone any other traumatic surgeries, or were there any history of trauma in that particular case? Is he or she suffering from some sort of systemic illnesses, for example, HIV, tuberculosis, hypertension? Is he taking some sort of drugs, such as is he prescribed with aspirin for a longer period of time? So all of these history questions are again very important when we have a patient of a red eye in the outpatient department, because sometimes it is quite clear, even when you are taking a complete detailed history from a patient, that what is the underlying causative factor for this particular red eye in this particular patient that we are dealing with. So the history is the mainstay, and then we move on to the clinical examination in this particular patient of the red eye. The clinical examination itself would reveal the complete story in a patient. The questions are put forward relating to the associated symptoms, such as pain, blurring of vision. The visual acuity is if it is checked, and if it is basically causing the blurring of the visual acuity, then obviously a lot of diseases are added or subtracted to the differential diagnosis or towards the final diagnosis in a particular patient. So over here in this section, we're going to deal with the different clinical examinations that we're going to perform in a patient, and what are the typical pictures that we usually observe in a patient of a red eye, and how we're going to get to a conclusion whether it is a benign sort of a disorder, such as conjunctivitis, episcleritis, scleritis, uveitis, blepharitis, or either it is quite a vision-threatening disorder. For example, the acute angle closure glaucomas can even present as the redness of the eyes initially. So the final prognosis or the final outcomes in cases of the acute angle closure glaucoma, it basically depends upon the initial or the accurative diagnosis as early as possible. Then we have blepharitis on the other hand, and we'll be briefly discussing this condition, as well as sometimes associated with the redness of the eye in the patient. The symptoms that are associated with acute angle closure glaucoma in most of the patients are the pain, headache, nausea, vomiting, redness, and photophobia in the patient. The reduced vision is a very common feature that is observed in these patients. They are usually presenting or with the complaints of halos around the lights, or photosensitivities, or the photophobias. So this is a typical picture of the acute angle closure glaucoma. Over here you can see these hyperemias that are observed around or on the sclera. Then we have a dilated pupil, and then when we calculate the intraocular pressure in these patients, usually they are giving you the intraocular pressures that are raised more than 20 millimeters of mercury in this particular case. So the different causes of red eye that we should keep in mind are the foreign body. Then we have the lymphoid follicles of viral conjunctivitis. The ciliary flush is noted down. We have the irregular pupils, episcleral vessels, monopurulent discharges, blepharitis, dendritic ulcers, conjunctival vessels, and the papilla of the allergic conjunctivitis. So these are the particular diagnosis, the differential diagnosis, the particular features or the clinical signs and symptomatologies that were noted down in a red eye. Making a definitive diagnosis in a red eye is sometimes quite tricky. When you are suspecting conjunctival diseases, subconjunctival hemorrhages are present in a lot of cases, you have to rule out the systemic hypertensions, vasculitis, coagulopathies, local traumas and jugular compression, history, blood pressure, coagulation profile, and hematology are very important over here. And then we move on to the conjunctival hyperemia that is present. If it is present, we have to rule out the episcleral hyperemia. Intraocular pressure or flare is noted down. Fluorescein staining is performed in this particular case to rule out the orbital diseases, the retropulsions, the conjunctivitis. Then we have some of the other tests that are sometimes prescribed to these patients. For example, Schirmer's test, It's basically a tear test, fluorescein staining, and then we have the culture, cytologies, and biopsies. On the other hand, we have the chemosis. If it is present, we have to rule out the infectious conjunctivitis, the allergic conjunctivitis, subconjunctival neoplasias, lymphomas, plasmacytomas, and the foreign body conjunctivitis. Cytologies, biopsies, and cultures are performed or investigated in this particular case. On the other hand, we have the mucoid discharge, and if it's present, we have to rule out the increased production of the conjunctivitis, the decreased hydration, and the keratoconjunctivitis scica, the Schirmer's tear test, fluorescein staining, culture, cytology, and biopsies are performed in this particular case. Then we have to perform the conjunctival mass. If it is present, we have to rule out the neoplasias, immune-mediated diseases, for example, granulomatous episcleritis, feline eosinophilic keratoconjunctivitis, cysts have to be ruled out, chalazions have to be ruled out. The conjunctival thickening, if it is present, we have to rule out epithelial disease, chronic conjunctivitis, subepithelial disease, tarsal glands or meibomian glands may be involved over here. Blepharitis, lymphomas, and plasmacytomas have to be ruled out over here while we are performing this. Schirmer's tests are performed, fluorescein staining, cytologies, and biopsies are taken in this particular case. We have blepharitis on the other hand, that is basically an inflammation or infection of the eyelid margins. Ophthalmologic complications or ocular complications are obviously there. One of the most difficult conditions to treat. The clinical features would include the ocular history, symptoms, predominant locations of the lid abnormalities are present over here. The lid skin is sometimes involved. The anterior lid margins and the lashes are involved. Posterior lid margins and meibomian glands may be complicated in the advancements of the disease. The signs and the symptomatologies over here, they would include the redness of the eye that is associated with the induration, cellulitis, eczematoid reactions, lichenification, that is basically the thickening of the sclera. Then we have the crusting that is associated due to the secretions or due to the purulent discharge that is associated with blepharitis when the meibomian glands are involved. And then we have the loss of the lashes, the lid margin ulcers and vesicles are noted, styes and chalazions are also noted down. The granulomatous inflammations are a part and parcel of this infection. And then finally, we have the papillomatas over here. The causative factors which can end up in blepharitis in a particular patient, they're associated with chronic dermatosis, such as seborrheic dermatitis, rosacea, that is acne rosacea, discoid lupus, atopic dermatitis, and psoriatic dermatitis on one hand. Then we have the another variants, that is basically the hypersensitivity or the immune variants. We have the contact dermatitis, we have the immune responses to staphylococcal diseases, and on the other hand, we have the infectious group, which would basically include the bacterial, the viral, and the fungal infections. So these are the causative factors which can end up in blepharitis or the lid margin infections in a patient. Even we have the parasitic variety for the infectious states over here. Differentiating the staphylococcal type of the infections from the seborrheic infections, which can result in blepharitis, the age is usually 42 years in staphylococcal infections and 50 years in seborrheic infections. The findings in staphylococcal infections are hard, adherent crusts pierced by cilia or collarettes. In seborrheic infections, we have the greasy, less adherent scales or scarfs over here. The cornea is usually marginal, infiltrates are found, and tenolosis is basically associated with staphylococcal infections. In seborrheic infections, we have the inferior SPEs noted down. The tear film is unstable and rapid break time is associated with staphylococcal infections. In cases of seborrheic infections, we have the aqueous tear deficiency in 1/3. The treatment is associated with antibiotics, scrubs, and warm compresses. Seborrheic dermatitis, the treatment is eyelid scrubs, warm compresses, and selenium shampoo. So warm compresses is something that is the treatment of choice in both of the cases of blepharitis over here. So in this section, basically, we summarized the different miscellaneous diseases that are associated with a red eye in a patient. So that is the end of this section. Thank you for watching sqadia.com.